episode, I am going to talk about alpha blockers. The outline of the presentation will consist of the classification of alpha blockers and the therapeutic uses and adverse effects of alpha blockers. What are alpha blockers? The alpha blockers are the drugs that block adrenergic responses mediated through alpha receptors. The alpha receptors are of two subtypes, alpha 1 and alpha 2 receptors. Before we move on to the therapeutic uses and adverse effects of alpha blockers, it is important to know the location of alpha receptors, the functions of alpha receptors, and what are the effects if the alpha receptors are blocked. Now, the effects can be desirable or undesirable. The desirable effects can be exploited for therapeutic uses, whereas the undesirable effects manifest as side effects. So let's talk about the effects of alpha blockers. The effects of alpha blockers relate with the location of alpha receptors and the functions of alpha receptors. The location of alpha 1 receptors. The first location. Alpha 1 receptors are located in the smooth muscles of the blood vessels, and stimulation of these receptors causes vasoconstriction, increase in peripheral vascular resistance, and rise in blood pressure. Therefore, blocking these receptors results in vasodilatation and a fall in blood pressure. Therefore, alpha blockers are used for lowering the blood pressure and they are used as antihypertensive agents. Alpha 1 receptors are also located in the small arteries of the skin and mucosa. Stimulation of these receptors causes constriction of the blood vessels, decreasing the blood flow to the skin and mucosa, and can cause dermal necrosis. Therefore, blocking these receptors dilates the blood vessels, increases the blood flow to the skin and mucosa. And this is why alpha blockers are very useful for the treatment of peripheral vascular diseases such as Raynaud's phenomenon, frostbite, and other peripheral vascular diseases. In nasal mucosa, constriction of the blood vessels decreases the blood flow, the blood volume to the mucosa, resulting in shrinkage of the nasal mucosa. So by blocking these receptors, the blood flow increases, dilatation of blood vessels increases, blood flow increases, the blood volume increases, and this can lead to congestion of the nasal mucosa and leading to a side effect, that is nasal stuffiness. Alpha 1 receptors are also located in the bladder neck and the smooth muscles of the prostate. Stimulation of these receptors increases the smooth muscle tone, decreasing the urinary flow. Therefore, by blocking these receptors, the urinary flow increases, and this is very helpful for treating lower urinary tract symptoms in patients of benign hypoplasia of prostate. Alpha 1 receptors are also expressed in the vas deferens and ejaculatory duct. Stimulation of these receptors causes constriction of the ejaculatory duct, causing ejaculation. Blocking these receptors causes ejaculatory dysfunction. Alpha 1 receptors are also present in the radial muscle of the iris. Since the muscles are radially arranged, activation of alpha 1 receptors causes contraction of the radial muscle of the iris, leading to dilatation of the pupil. So blocking the receptor results in miosis. Alpha 1 receptors are also present in the GI tract, and stimulation of alpha receptors decreases the GI motility and decreases the GI secretions. By blocking these receptors, the GI secretions increases and there can be diarrhea. So diarrhea can be a side effect of alpha blockers. So in general, the therapeutic uses of alpha blockers are: number 1, they are used as antihypertensive agents. 2, they are useful for the treatment of peripheral vascular diseases, Raynaud's syndrome, frostbite. 3rd, they are useful for the treatment of benign hypoplasia of prostate, providing symptomatic relief from urinary symptoms. They are also useful drugs for the treatment of pheochromocytoma. So what is pheochromocytoma? Pheochromocytoma is a tumor of the adrenal medulla which releases large quantities of catecholamines. So these catecholamines result in excessive sympathetic activity, resulting in hypertension and tachycardia. So to control hypertension and tachycardia, these drugs are useful for the management of pheochromocytoma and diagnosis of this disease. So now let's move on to the location of alpha-2 receptors. Alpha-2 receptors are located in the presynaptic nerve terminals of the adrenergic neurons. Norepinephrine is synthesized and stored in the synaptic vesicles of the adrenergic neurons. The function of alpha-2 receptors is to inhibit the release of norepinephrine into the synaptic cleft. So alpha blockers, by inhibiting the alpha-2 receptor, increases the release of norepinephrine, and increased norepinephrine concentration stimulates the beta-1 receptor of the heart, leading to tachycardia. So significant tachycardia occurs due to additional alpha-2 blockade action, enhancing the release of norepinephrine and epinephrine, resulting in beta-1 receptor stimulation of the heart and significant tachycardia. This is particularly a matter of concern in elderly patients who are at increased risk for cardiovascular events. So tachycardia is a side effect with non-selective alpha blockers that block alpha-2 receptors in addition to blocking the alpha-1 receptors. Therefore, non-selective alpha blockers are not preferred as antihypertensive agents as they can cause significant tachycardia in elderly patients. Next is classification of alpha blockers. The alpha blockers can be classified on the basis of receptor selectivity and their mode of action. So alpha blockers are divided into non-selective alpha blockers and selective alpha blockers. Drugs that block both alpha-1 and alpha-2 receptors are non-selective alpha blockers. So they can be further subdivided into reversible and irreversible alpha blockers. Drugs that are reversible in nature are phentolamine and tolazolene. Irreversible non-selective alpha blocker is phenoxybenzamine. The next is selective blockers. The drugs that selectively block alpha-1 or alpha-2 receptors are selective alpha blockers. Selective alpha-1 blockers are trazosine, teirazosine, doxazosine and tamsulosin, and alpha-2 blocker is yohimbine. So now let's talk about the non-selective alpha blockers. The non-selective alpha blockers are of two types, irreversible and reversible. Phenoxybenzamine is an irreversible non-selective alpha blocker. It forms strong covalent interactions with the active site on the alpha receptor, and because it forms strong bond interactions with the alpha receptors, the effects are unsurmountable, which means that excessive quantities of epinephrine and norepinephrine are not able to displace the drug from the active site on the receptor. So the effects are unsurmountable. It has a long duration of action because of strong interactions with the receptor, and it is the preferred drug for the management of pheochromocytoma. Phentolamine, on the other hand, is a reversible non-selective alpha blocker. The interactions with the alpha receptor are weak. They can easily be displaced from the receptor. So the effects are surmountable, which means that increased quantities of epinephrine and norepinephrine can displace the drug from the active site on the receptor, preventing the action of the drug on the receptor. So the effects are short-lasting. The drug has a rapid onset of action and the duration of action is very short. Therefore, this is useful for the diagnosis of pheochromocytoma, and the test is known as phentolamine test. So what is phentolamine test? If after giving 5 milligrams of phentolamine, there is a fall in blood pressure by 25 to 35 mm of mercury, it is a case of pheochromocytoma. If the blood pressure reduction is less, it is a case of essential hypertension. This is how pheochromocytoma is differentiated from essential hypertension. The other uses of phentolamine is, it is useful for the treatment of peripheral vascular diseases to counteract the alpha receptor mediated vasospastic component in the extremities, as in Raynaud syndrome, frostbite, and so on. It is also useful for the treatment of hypertensive crisis after abrupt withdrawal of clonidine. It also prevents dermal necrosis caused by extravasation of norepinephrine from IV infusion. Now that we have learnt about non-selective alpha blockers, so let us now compare the effects of non-selective alpha blockers with the selective alpha blockers. The non-selective alpha blockers block the alpha-1 receptors of the blood vessels. So this causes vasodilatation, decreased peripheral resistance and fall in blood pressure. Decrease in blood pressure causes decreased activation of baroreceptors, resulting in reflex tachycardia. Non-selective alpha blockers also block alpha-2 receptors. So blocking the alpha-2 receptors results in increased release of norepinephrine and excessive sympathetic activity. So increased norepinephrine stimulates the beta-1 receptor of the heart, resulting in significant tachycardia. So tachycardia in case of non-selective alpha blockers is due to alpha-1 action, alpha-2 action and beta-1 action of the heart. Moving on to selective alpha-1 blockers. The selective alpha-1 blockers, by blocking the alpha-1 receptors of the blood vessels, causes a fall in blood pressure and reflex tachycardia. But they have no action on alpha-2 receptors. So the lack of action on alpha-2 receptors results in lesser tachycardia compared to the non-selective alpha blockers. Therefore, selective alpha blockers are preferred for the treatment of hypertension, and non-selective alpha blockers are more likely to cause tachycardia, and this is particularly a matter of concern in elderly cardiac patients as they are more prone to ischemic heart diseases. So let's now focus our talk on selective alpha-1 blockers. The alpha-1 selective blockers are prazosin, terazosin, doxazosin and tamsulosin. Prazosin is a highly potent drug and has selective action on alpha-1 receptors of the blood vessels, causing a fall in blood pressure, and therefore they are commonly used as antihypertensive agents. Prazosin has a duration of action of 6 to 8 hours, therefore they can be given twice daily or thrice daily. They have good oral bioavailability and the bioavailability is about 60%. Common adverse drug reaction related to prazosin is first dose hypotension. What is first dose hypotension? An initial dose of prazosin can cause marked postural hypotension, and this can result in fractures, falls and syncope. Therefore, to avoid this side effect, prazosin is started at a very low dose of 0.5 mg and it is taken at bedtime. The other adverse effects related to prazosin are headache and dizziness. Now let's talk about terazosin. Terazosin is also a highly selective alpha-1 blocker, a potent drug, reduces blood pressure, useful for the treatment of hypertension. Terazosin has a longer duration of action compared to prazosin and has better bioavailability. The first dose hypotension can also occur with terazosin, but the side effect is less frequent. Terazosin has a specific effect, which is it induces apoptosis of the smooth muscles of the prostate cells. Therefore, it is a preferred drug for the treatment of a patient with hypertension and benign hypoplasia of prostate. Tamsulosin has highly selective action on alpha-1A and alpha-1B receptors, which are present in the smooth muscles of the bladder. It has less selective action on alpha-1B receptors present in the blood vessels. The selective action on receptors of the urinary bladder makes them uroselective in nature, and they have lowest potential to decrease the blood pressure. Therefore, they are preferred drugs for the treatment of lower urinary tract symptoms associated with benign hypoplasia of prostate. Tamsulosin is also associated with increased incidence of retrograde ejaculation or delayed ejaculation.
These are my references. Thanks for watching. Please like, subscribe and share.